So remember, the trigeminal nerve is the main sensory nerve of the face and the deep structures of the face, so the nasal cavity and paranasal air sinuses and so on. There are also some branches that are responsible for carrying sensation from the scalp. It also is responsible for the muscles of mastication, and therefore when we're testing trigeminal nerve function, we test both the dermatomal distributions, so soft touch in the dermatomal distributions, and the muscles of mastication. Not forgetting another test of trigeminal nerve function, although we don't tend to perform it that often clinically unless we're worried about trigeminal nerve function, is the corneal reflex. So the trigeminal nerve is very important in terms of the afferent limb of the corneal reflex, which is when you reflexively close the eyelids in both eyes following stimulation to the front of one eye. So the stimulation to the front of one eye is the afferent signal is sent through a branch of the trigeminal. So remember, we've got the ophthalmic division, and we have the ophthalmic, maxillary and mandibular divisions of the trigeminal nerve, and they're all sensory, general sensory, but not forgetting that the mandibular division is also motor. So it's the only branch of the trigeminal nerve that is carrying motor as well as sensory information. So it is quite a complicated cranial nerve. It feels like there are perhaps quite a few branches to remember, but if we work from the divisions and consider some of the key branches of the divisions, then hopefully we can make a little bit more sense of it. So this is just a reminder of the dermatomal distributions of those three divisions. So we'd like to touch those three areas. And coming to the root then of the trigeminal nerve, remember that the trigeminal nerve is a cranial nerve that is topographically related to the pons. Inside the brainstem, the trigeminal nucleus is actually quite an extensive nucleus, running almost the length of the brainstem, but it exits the brainstem at the level of the pons. When it exits the pons, it very quickly becomes the trigeminal ganglion is found, and it's from here that we see the three divisions of the trigeminal nerve rising. Two of those we know run through the cavernous sinus and the lateral wall of the cavernous sinus, whereas the third one, the mandibular division, is going to run down along the middle cranial fossa, along the floor, towards a hole which will take it to outside of the skull. So if you can remember, the mandibular division exits the base of the skull through the foramen ovale. Okay. The first two divisions, ophthalmic and maxillary, after they've run through the cavernous sinus, so at this point they're going to be within the region of the middle cranial fossa, because the cavernous sinus is that venous structure that's sitting either side of the sella turcica, so we're in the region of the sphenoid bone just here. Once they've gone through the cavernous sinus, we know that the ophthalmic and the maxillary divisions take slightly different routes. So if we follow our ophthalmic division first, and the reason that I've got arrows pointing in the other direction is just to remind us that actually the direction of sensory information is going to be this way, isn't it, from peripheries to the brain. So the ophthalmic division is going to need to get into the orbit to supply orbital structures. So it will enter the orbit through the superior orbital fissure. And it gives a number of branches, does the ophthalmic division. We've got the lacrimal branch, which will obviously innervate the lacrimal nerve, lacrimal gland. And we also have the frontal nerve, which extends up out of the orbit and onto the forehead. So this is how the ophthalmic division gives rise to sensory innervation to the skin of the forehead and the scalp. And we also have the nasociliary nerve, which is giving a number of other sensory branches, supplying other structures of the eye, and so on. So that's our ophthalmic division. The maxillary division, if we follow that, so it comes again through the lateral wall of the cavernous sinus, and then it goes through a slightly different hole, and this is the foramen rotundum. And once it's gone through the foramen rotundum, it goes into a very, very tiny space known as the pterygopalatine fossa. And it will give a number of branches, many branches, which you don't have to worry too much about, but there's a couple that I have wanted to draw your attention to, which is the infraorbital nerve, which runs through the floor of the orbital cavity and then emerges through the infraorbital foramen to obviously be taking sensory information from that region of the face, or just the lower eyelid and around the cheek. We also have superior alveolar nerves, and these are carrying sensory information from the upper jaw, the teeth and the gums, and maybe targets for local anaesthetics, particularly in dental treatment on teeth involving the upper jaw. So that's the ophthalmic and the maxillary divisions, and we'll come back to some of the clinical implications of just understanding some of those branches. If we follow the mandibular division now, so this was the one that's carrying sensory as well as motor, hence why we've got green as well as purple. We said it goes through the foramen ovale, so it exits the skull to be outside of the skull, and it runs into an area known as the infratemporal fossa. So this is that irregularly shaped space that's just medial to the mandible and just beneath the base of the skull. In there, it's going to give lots and lots of branches. It's going to give those motor branches to the muscles of mastication. And it's going to give off a couple of really important sensory branches. So we've got one that's going to be running to the tongue and carrying general sensory information from the anterior 2/3 of the tongue, and that would be our lingual nerve. We also have another branch that runs relatively close to the lingual nerve, but then disappears through a hole on the inner surface of the mandible, and then runs through a bony canal in the mandible itself. And this nerve here is known as the inferior alveolar nerve. And it emerges on the front of the mandible through the mental foramen as the mental nerve. So the mental nerve just here is going to be what's receiving information from the lower gum and the front few teeth of the lower jaw and the skin of the chin, and then that information will be directed through and back via the inferior alveolar nerve. And the other branch, sensory branch, just to remind ourselves of, is the auriculotemporal nerve, and this nerve would run up towards the lateral side of the head, towards the temporal region, and also supply sensory information to the temporal mandibular joint as it's passing. So those are the three divisions of the trigeminal nerve, VA, VB, VC, and we've followed the roots of those three divisions and considered some of their subsequent branches that are important to be aware of. So let's think about some of the kind of reasons why understanding the root and some of the branches of these divisions is important. So if we come in at the level of the ganglion, you learnt in nervous system that there is a type of headache which patients can present with, known as trigeminal neuralgia. And one of the causes for that trigeminal neuralgia may be due to an aberrant blood vessel or a branch of a blood vessel that is impinging in the area of the trigeminal ganglion. And patients with trigeminal neuralgia, remember, present with quite severe electric shock shooting pains, often felt in one of the distributions of the trigeminal nerve. Following the mandibular division, and thinking about the fact that this inferior alveolar nerve runs through a bony channel in the mandible, that should a patient experience a fracture through the mandible, you can see how the inferior alveolar nerve is going to be very vulnerable to injury. So any sensory information that was being brought in via the mental nerve and along here, so the inferior alveolar nerve would have been taking or receiving sensory information from the teeth and the gums along its root of the lower jaw. So the fracture at this point is going to interrupt that information being able to work its way back along the rest of the root of the trigeminal. Coming to the maxillary division, and as we followed that forward, and we said that many of the branches are responsible for carrying sensory information from the very sort of deep facial structures. We also have this infraorbital nerve, and because it runs through the floor of the orbit, so this here is supposedly demarcating the orbit looking from the side, and here's an eyeball. Because this infraorbital nerve is running through the floor of the orbit, when you have orbital floor fractures, as you might get in a direct trauma to the front of the eye, that nerve is particularly vulnerable to injury as it's running through the floor just there. So what happens is you interrupt the nerve, which would have been carrying, again, sort of sensory information from the area of the face just there, and it's been interrupted at this point, so the signals don't get back to the brain for interpretation. So we get an area of loss of sensation. And on a CT scan, which is often what we order when we're suspecting an orbital blowout fracture, so here would be the left orbit, and we can see here by the arrows that the floor of the orbit has been disrupted. And one of the consequences of an orbital blowout fracture is that some of the orbital contents become trapped in that fracture site, and the patient will struggle to elevate the left eye in this case, because it's been nipped at the bottom within the fracture site. So one of the things that we would test is whether the patient is able to follow our finger upwards with both eyes. What we might also see if we had it in view is these two black cavities are the maxillary sinus, so we may have seen a fluid level which tells us that there's been some bleeding into the space just beneath the orbit. So infraorbital nerve, you'd want to test sensation in the area of the face that nerve supplies as part of your workup in a patient who you suspect may have an orbital blowout fracture. So that's the trigeminal nerve. So we said 3 divisions, a few branches of each of those divisions just to be aware of, and how they may be injured in certain types of trauma, but also remembering that the trigeminal nerve can also be involved in a type of headache called trigeminal neuralgia as a result of compression to earlier parts of its root. The other thing just to add is that again at the level of the ganglion is you can sometimes develop ophthalmic shingles. So because this is a ganglion just here, and we know that in other areas of the body that ganglions can be sites for previous virus infections to lie dormant and to be reactivated at a later stage. So sometimes patients who've had varicella zoster or chickenpox, that virus may lie dormant in the trigeminal ganglion. And later on, when the virus is reactivated, for example in periods of stress, the result can be the development of vesicles in one of the distributions of the trigeminal nerve. And if it does involve the ophthalmic division of the trigeminal nerve, we are very concerned that there may be involvement of the front of the eye and the orbital structures, because the ophthalmic division is responsible for carrying sensory information from the front of the eye, the surface of the eye, as well as other orbital structures. So I think that kind of concludes and sums up some key points on the 5th cranial nerve, trigeminal nerve.